an international medical education conference representing North Zone of DMER to commemorate Diamond Jubilee celebration of DMER in the vibrant city of Thiruvannamalai. Day one presentations explored innovative ideas, challenged us to think differently, and left a lasting impact on everyone here with the power to shape their future. So without any further delay, let's drown into the world of innovation, exploration with our finger crossed and ears open. Shall we? Thank you. So to begin with today's feast of knowledge, we take immense pleasure to welcome our first speaker of the day, our quantum speaker, respected Dr. Rashmi Vyas ma'am. We would like to welcome the chairpersons of the session, Dr. Celine ma'am, Professor of Physiology, Chengalpet Medical College and Hospital, and respected Dr. Hema Chandrika madam, MD Physiology, former Vice Principal, Curriculum Committee Chairman, and a vibrant PG Director, Lalitambige Medical College and Hospital, to introduce the speaker and start the session. Thank you.
With thanks to the Lord, a warm good morning to one and all. It gives me immense pleasure to introduce our distinguished speaker for today, Dr. Rashmi Vyas. Madam currently serves as the Vice President of Intealth. Intealth is a global center committed to strengthening the health workforce by enhancing education and training of healthcare professionals. Madam is also the Senior Director of FAIMER. We are happy that she's part of our own department. Madam is a physiologist also, and she has served as a professor at CMC Vellore. And she had made significant contribution to medical education with over 50 scholarly publications. We feel truly privileged to have Madam with us today to benefit from her rich experience and insights. Over to you, Madam, on the session Workplace-Based Assessment.
Good morning, Madam. Physiologist is addressing a gathering by two physiologists as chairperson. I am very happy to see you. I met you in Ludhiana conference. Thank you.
Thank you very much for that kind introduction. I'll get started by sharing my screen. And wonderful to be here with all of you. I thank the organizers for inviting me as you are deliberating on leveraging best practices in medical education. My name is Rashmi Vyas, as I've already been introduced. And between yesterday and today, I've had a slight change in my title. I'm still involved and lead FAIMER Global as Vice President of FAIMER Global. I bring you greetings from Philadelphia, USA. What I'm going to do is I'm going to share my thoughts on workplace-based assessment. The organizers have asked me to give an overview, and so that is what I'll bring to you. I will be demystifying workplace-based assessment, what it is, why is it valuable, educational theories behind it, tools you can use, and then round it up with practical tips of how to integrate it into your workflow, the importance of efficient observation and actionable feedback. So let's start with what is workplace-based assessment. Many of you may be familiar with it, some may not. So I'm starting with the ground level. So all of us have the same, looking at the same definitions. So workplace-based assessment, what it does is it provides a holistic view of the progress of your learner, of our learner, towards becoming independent and practicing unsupervised, having clinical practice unsupervised. So basically, it is assessing the performance of the learner in the clinical setting, in the clinical environment, or they say real workplace environment. The focus is on what the learners actually do versus the knowledge-based tests that we have. And the key essential features are the teacher or the assessor does direct observation of the learner's performance and providing structured feedback. So direct observation and structured feedback are essential. So it's about assessment of learner performance in authentic clinical practice. So the educational rationale, there are two underpinning foundations linking workplace-based assessment. One is competency-based medical education, which is taking the world by storm. And I know definitely India, where all medical schools have to implement competency-based education. And the second is extended Miller's pyramid. So competency-based medical education has come over more than 2 decades. And it is an outcomes-focused approach to learning, training, emphasizing demonstration of competence rather than the current time-based progression that we have. What has happened is, as competency-based medical education evolved, it created a gap in assessment. What it means is that CBME required assessment of performance in real clinical setting over a period of time. And the isolated assessments that are prevalent were insufficient to actually judge this competence. So thus came in the workplace-based assessment addressing this gap which was created by the evolution and requirements of CBME. What workplace-based assessment does is it supports the competency-based education. How? By providing assessment data. And what does one do with this assessment data? It helps the assessor, the teacher, to take decisions about the competency of our learner. And then we can make a plan. Once we know what the level of competency is, the teacher can make a plan to support the learning of the learner. And when I say teacher can make a plan, I'll take that back because it is about the teacher and the learner jointly in partnership making a plan to support the learning of the learner. So that's where workplace-based assessment comes in, and that's how it's linked with competency-based medical education. The second is extended Miller's pyramid. Most of you may be aware of Miller's pyramid, which came up several years ago and focuses on 4 outcome levels. Knows, which is about the knowledge which your learner has. Knows how, which is application of knowledge. Shows how, which is performance in standardized contexts such as OSCEs, the Objective Structured Clinical Examination. And does, which is performance in practice. And workplace-based assessment focused heavily on the does level of Miller's pyramid. So that was going on for more than 2 decades, and then came in as competency-based medical education evolved. What came in was the entrustable professional activities, or EPA, as a framework to assess competencies. And thus, it connected workplace-based assessment to entrustment decision-making. What does entrustment decision-making mean? It means that the teacher or the assessor trusts the learner to be able to perform or do the clinical practice in real-life setting without supervision, or at what are the level of supervision that learner needs. And thus, Oli Tenkate and others, they proposed the trusted level above the does level of Miller's pyramid. So they are proposing this extended Miller's pyramid where the highest level of assessment is to trust, about making entrustment decision. So basically what this extended pyramid does is it tells us that the goal of assessment is to ensure that the physician can be trusted to provide unsupervised patient care after completion of a program. And so the workplace-based assessment tools evolved beyond the does level to help the assessor make entrustment decision or go to the trusted level. So with CBME and extended Miller's pyramid as its underpinning educational work, why do we use workplace-based assessment? To a quick recap, it is embedded in clinical practice, tells us about real-world performance, aligned with competencies. It is feedback driven, and you will see that how direct observation and structured feedback is the core of workplace-based assessment. There are authentic real life encounters, and very important, it gives you longitudinal evidence of your trainee's performance. That means you are not testing, assessing your trainee at one time, but multiple times over a period of time. So, what workplace based assessment does, the benefit is that it helps the move learners from just knowing to reliably performing their roles in real life settings, because that's what we want, right? We want our trainees to go out in the world and practice in real life settings. So, workplace based assessment provides real life workplace based evidence so that we can support the learning and move our learners towards readiness for independent practice. And that's our goal, right? That's the goal of medical schools, health profession school, that we train our learners and make them ready for independent practice without supervision. So, what are the skills that we need? Learners and assessors both need, mainly the assessors, to implement successful workplace-based assessment. These are three main skills: direct observation, feedback, and coaching. What is direct observation in workplace-based assessment? It's a core component of almost all the workplace-based assessment tools. It is embedded in real clinical practice. That means you are observing your trainee in the clinical setup. It is focused on real-time performance. And then there are structured observation tools, and the assessor gives immediate, actionable feedback to the trainee. So, in a nutshell, direct observation allows the teacher or the supervisor or the assessor to assess real clinical performance and provide timely feedback, not once, but multiple times. So, the trainee or your student or your learner develops the competency in step-by-step manner, moving from novice towards expert level. These are some examples of tools for direct observation: the direct observation of procedural skills, mini clinical evaluation exercise. I will be talking a little more about the tools in just a few slides later. But what I would like to highlight are the key principles for direct observation. Remember, this is a skill which all of us just need to have for successful workplace-based assessment, which is there has to be multiple brief observations. You cannot make a decision about your learner based on just one observation. There have to be multiple supervisors. So one person cannot, their assessment cannot make the decision about the learner. There have to be multiple assessors, and their combined assessment will help make decision about the learner. There has to be multiple clinical context. Just one case or one procedure will not will not enable you to make entrustment decisions about your learner. You have to see them in multiple contexts. So basically what it means is no single observation is sufficient. It is aggregated observations which improve the reliability, and to do all this, training of the assessor is essential. It's very crucial that the assessor is trained to do direct observation. So these are some steps for direct observation in clinical encounters. So before entering the room, as an assessor, as a teacher, as a supervisor, you review which workplace-based assessment tool you are using. Then you talk to your student and set the expectations for direct observation. That means you tell them, I'm going to observe you taking history or whatever you're going to do. And that then I'm going to take notes. And then when we leave the room, I'm going to provide you with feedback. And then with the learner, you identify the learning goals. So the learner may say, oh, I have some problem in eliciting this history or doing this physical exam or doing this procedure. So you identify the learning goals and make a plan about your direct observation focused on the learning goals. Okay. Then both of you enter the room. Once you enter the room, as a teacher, you explain your presence to the patient. that what is your role, and then you just position yourself so that you can observe the learner. Now, during the observation of the clinical encounter in the room, make sure you're taking specific notes on the behavior you're observing. Avoid interjecting or minimizing interruptions. Then after the observation, come out of the room, complete the workplace-based assessment tool. Remember, all these tools, these are actually tools. These are validated tools, and I'll be talking about them in a minute. They include narrative comments. That means you will give narrative feedback and then talk to the learner and provide the learner with actionable feedback. As you can see, the point I'm trying to make is observation does not come naturally. It is a learned skill. There is a structured format to it, which the teachers have to learn, explain to the learner, and work with the learner to make it a learning experience for the learner. So it's all about supporting the learner. The second skill, which is a must-have and critical, is feedback in workplace-based assessment. Feedback, like direct observation, is a core component of every workplace-based assessment tool, and it is a key driver of learning. So if the feedback is effective, it will support self-directed lifelong learning. That is what we keep on talking about. Both the assessor and learner, they require skills to give feedback, seek feedback, receive feedback, and use feedback. So this is one skill set which both the assessor and the learner has to be trained on. So the traditional one-way feedback models, which we have been using for a very long time, for example, the sandwich method. I don't know if maybe some of you, most of you know it. So the sandwich method is you give appreciation to the learner, followed by criticism, and then again sandwiched, again followed by appreciation. So there are two layers of appreciation, and in the middle is the level of criticism. Now, in the current evolvement, it's not recommended in workplace-based assessment. Instead, evidence-informed models which emphasize feedback as a dialogue, as a conversation with the learner, is what is recommended for workplace-based assessment. One example of such feedback model is called prepare to adapt. Prepare to ADAPT. This model, and there are other models which are like dialogue models. So this prepare to adapt model replaces the one-way feedback sandwich models, and here feedback is as a conversation. So what are the things here? So there is prepare, perform, and then there is adapt. Adapt is ask, discuss, ask, plan together. So in prepare, both the learner and the assessor prepare deliberately. You have that conversation. What is the learning goal? What is that is going to be observed, and why, and so on. Second step is perform. Both the assessor and the trainee are engaged in the actual assessment. So the learner does the task, and the teacher or the supervisor observes the learner doing the task. Then both step out. And now starts the adapt. So the first task is the trainee, the learner may have specific feedback questions for the assessor. And what the assessor does is it asks the learner first for a self-assessment. Okay? Then followed by discuss. The assessor engages the learner in a conversation. Then comes the next ask, where the learner asks for any clarification and the assessor checks for clarity. And then is planned together. Both the trainee and the assessor develop a plan collaboratively. So you can see this is not teacher directed. This is collaborate planning of learning and structured feedback. The third skill, which is essential in workplace-based assessment, is coaching skills. Coaching is different from mentoring and advising. Mentoring is when you are also an expert in that area, you support your learner in their professional growth, in their psychosocial growth, and you say, for example, you write a paper together. So you may also be part of the learning elements of the learner. Advising is when you are an expert in that field and the learner has a question and you answer that question specifically. So for example, a resident in surgery, right? If you are a surgeon, you may be a mentor for your learner. But if the learner has specific questions, say about liver transplant, you will connect them to a liver transplant expert who will now become an advisor answering that specific question. But coaching is you are constantly with the learner. You may not be that subject expert, but you are a global expert, and you help the learner to reflect, have self-directed learning, create learning goals by asking questions, by asking the right questions and providing feedback. And it's a lot of emphasis on reflection. So that prepared to adapt the feedback framework, which I just talked about, it uses the coaching principles. And that's where the link between coaching and workplace-based assessment comes in. So how does it look like? How will coaching and workplace-based assessment look like? You will observe a real clinical experience of the learner. You will ask the questions to help the learner reflect on their clinical experience. Then again, you will ask questions and work with the learner, could go design a plan for improvement. Then again, you will follow up through re-observation and feedback, and the cycle continues. So the workplace-based assessment tools, they provide the structure for coaching conversations, and it supports goal setting, reflection, feedback, improvement planning, all of which are principles of coaching. So workplace-based assessment, it supports a coaching model of supervision. Why and how? Structures reflection, structures feedback, and brings in a continuous improvement process in real clinical practice. So now that you know that these are the 3 skills that you just need to have, skills in direct observation, skills in structured feedback, and skills in coaching, now you have to choose your tools. What are the workplace-based assessment tools you will choose? This is assessment. So we need to follow the guiding principles or the criteria for good assessment practices. So while selecting the workplace-based assessment tool, use these criteria, the criteria of reliability, of validity, feasibility, and acceptability of workplace-based of any assessment tool. So reliability means a quick recap. The results of the assessment would be the same if it is repeated under similar circumstances. Validity of an assessment tool is that the result of the assessment are appropriate for a particular purpose. Feasibility of an assessment tool is that the assessment is practical, it is realistic, and so on. Acceptability of an assessment tool is that the stakeholders, for example, the teachers, they find they are able to use the assessment tool. So remember these 4 criteria you need to use when you select your workplace-based assessment tool. However, there's another index which is critical, which is the utility index. If you see, utility has 5 elements in it: reliability, validity, acceptability, educational impact, and cost. If any of these, the lower the level of these elements, the lower the utility. And if any of these 5 elements is 0, that means the utility of the tool is also 0. So as an educator, when you are thinking about assessment tools, and now when you're thinking of workplace-based assessment tools, this simple formula can be very helpful. The higher the utility, better is your tool. And especially in developing world where, some tools are coming from developed world, it may not be a very high fidelity simulation, may not have utility in a different context. So we have to be very careful and balance what is most acceptable, most useful, or in the assessment world, what has most utility in our context. And then comes this whole plethora of programmatic assessment. So when you're thinking of workplace-based assessment, you have to think of a program of assessment. It is not one single assessment. It means you are doing assessment multiple points at multiple points using multiple methods, and you document all these evidence and then decide, make a judgment about the competency of the learner. So this is an example of program of assessment in a program. If you see, there is needs assessment done, and to get the baseline knowledge, there is OSCE has been done. And then throughout the year, it is interspersed with mini clinical exercises throughout. And then in between, there is probing for clinical reasoning using case-based discussion and chart-stimulated recalls. And it is interspersed with faculty global evaluation, and they maintain longitudinal case. And in between, there is multi-source feedback also. At the end, at the exist assessment, there is no one single assessment. You look at their performance through all these assessment that has happened. And then you decide what is their level and what is the judgment about their competency. This is a list of common workplace-based assessment tools. There are just so many of them. There is direct observation of clinical skills, of procedural skills, multi-source feedback, assessment of clinical and therapeutic reasoning, global performance evaluation, and so on. Most of these tools, almost all these tools listed here, they meet the criteria of good assessment, which I have just shared with you. But remember, these are not concepts. These are specific tools, specific forms. And if you say, oh, I'm going to do mini clinical evaluation exercise, you have to use that form and do it in that way so that it meets the assessment criteria. Otherwise, your workplace-based assessment is not a workplace-based assessment. I will just quickly share a few tools. So let's look at direct observation of procedural skills, also called DOPS tool. DOPS uses direct observation, narrative feedback, and entrustment rating to assess procedural competence. For example, it could be drawing blood, central line, any procedure. So if you look at the tool, the validated tool, there is a rater assessment form. So you observe, then you step out and first fill in this rater assessment form, which is the narrative feedback. What did you observe about your student? What deficiencies and errors were committed? Based on your observation, what would you prioritize as the learning goal, and so on. And the second part of this validated tool, if you look, there is a rating scale. And there are items here around procedural skills. There is knowledge, did they take informed consent, appropriate analgesia, etc., etc. And you as an assessor will now make a decision about their supervision and entrustment. And it starts from level 1, which is the lowest level, where you say, oh, my learner doesn't know enough. He or she can only be an observer. And it moves up to number 5, where you say, oh, my learner knows all, and now they can practice unsupervised. So our goal as teacher and through these workplace-based assessments is to slowly help the learner move from level 1 to level 2 to level 3 to level 4 to level 5. That is why we need multiple times assessment in multiple ways by multiple people to help them move through in this continuum. If we look at direct observation of clinical skills, it includes tools that will assess clinical competencies of your learner, such as history taking, physical exam, etc. One such tool is the mini clinical evaluation exercise, or mini CX. You have repeated observations, which helps you to make entrustment judgments about the clinical performance across diverse settings. You can do it anywhere, OPDs, wards, emergency, etc. And then it has evolved into the adapted mini clinical exercise. Again, there is narrative feedback first, there is observation, the narrative feedback, and then making a judgment about the competency of the learner. So similar to DOPS, if you see the tool, the validated tool, there is narrative feedback first. You observe, then you step out, you fill out the narrative feedback, and then you fill out the rating scale. And here the items now are about medical, history taking, physical exam, etc. Again, the goal is to do it multiple times to help your learners learn and move from level 1 to level 5. Then there is multi-source feedback. The tool, it is a 360-degree feedback from patients, peers, and healthcare team members. It provides a holistic view. It is generally used for formative feedback, and it's appropriate for learners at all stages of training. And then there is assessment of clinical and therapeutic reasoning. So clinical reasoning, what is it? It involves integrating knowledge, pattern recognition, hypothesis generation, and decision making. Now, assessing this clinical reasoning in the workplace is very complex and difficult, and it requires exploration of the thought process of your learner. So case-based discussion tool is one tool which you can use as to assess clinical reasoning in as a workplace-based assessment. So here what you will do is you will have structured dialogue. You will talk to your learner, ask questions to understand the thought process of the learner in making diagnostic decisions, in making patient management decisions for a case managed by the learner. So your learner is now managing a case. You will regularly have discussions with your learner, asking questions. Oh, why did you choose this diagnosis? Why not this? Why did you order this investigation? Why not that? Why did you want to manage like this? So that is how you probe the clinical reasoning. And case-based discussion can be a good tool to do that as a workplace-based assessment tool. So what are the challenges? One is there could be variable quality of observation and feedback, because many a times that is implemented inconsistently. Not enough direct observation, feedback is not good. Second is about questionable authenticity and validity of judgments. So we are saying that workplace-based assessment, it is measuring in authentic, real-world clinical scenarios. But if it's just brief, opportunistic observations, it does not really represent a learner's true performance. There could be tension between formative and summative. Ideally, workplace-based assessment are meant for learning, so formative assessment, but they are used for high-stakes decision. In that case, the assessor, the teacher's behavior will be different, honest feedback may not happen, and thus learning will not happen. And then there are implementation challenges, which we all know. There are time constraints, we have clinical workload, and very importantly, faculty may lack the assessment skills. So what are the strategies to improve? Faculty development. And I will say it, I cannot say it loud and clear and again and again. It is essential to train the faculty to get quality workplace-based assessment. And the training has to be in those three areas, which we talked about in detail: in direct observation skills, ability to provide structured feedback, which is as a conversation and a dialogue, and apply the coaching principles for the learners. And of course, we have to follow the good assessment criteria in our choice and use of workplace-based assessment. So to summarize, workplace-based assessment focuses on real-world performance and readiness for practice. It operationalizes competency-based education. How? Through observation, feedback, entrustment. Multiple tools have to be used. Multiple observations have to be made. That is what will strengthen our assessment decision. And again, faculty development is very critical for effective workplace-based assessment. So what can you do next? As soon as you go, you can start by embedding small observations into your daily practice and your daily interactions with your residents, with your students. Remember, prioritize narrative feedback. Give them this feedback. What did they do well? What could they improve? And then talk with them, discuss with them to make learning goals. Observe multiple times across multiple contexts. And then use the tools, all these workplace-based assessment tools, to coach the learners. Remember the coaching principles? You talk to them in a structured manner, which helps them to learn, not simply just assess the learner. And foremost, build the faculty assessment skills. So on that note, thank you very much for your patience. And I wish you all the best as you move ahead in deliberating the rest of the day in leveraging medical education. Thank you.
And informative talk. And you have put the importance of the extended Miller's pyramid, where the dust level to trusted level. It is very important in the level of PG's assessment. Now the CBME is included in our PG curriculum, that workplace-based assessment as an important one to train our PGs to a higher level. So when they go to the community and serve, that will be very useful for them, and prepare to adapt. And the utility index, and how it will be become zero when the reliability, validity, and the acceptability is multiplied, and assessment at multiple points using multiple tools and multiple levels is an important one. And common work-based tools, very informative, and challenges what we face and how to overcome them. Thank you, madam. Any questions from the audience?
Madam, one question from my side. We don't routinely use this workplace-based assessment in the CBME for UG. Because till final year, they are not the part of the medical team. And one area where I feel we can incorporate is the patient-doctor clerkship. And the second area, can we extend this WPBA into the CRMI duration? Is it, if it is possible, I think the outcome will be better. What's your idea on this one?
I don't know what CRM is, but having said that, so the
House
area.
House
so the-
agency, madam.
Okay. So actually, again, what I have provided is the overview. So you have this information. Take that information and see what is feasible in your context. And you're absolutely right. Our postgraduates, they do clinical practice, and it is directly relevant to them. For undergraduates, also to some extent, in certain things where they have to do some procedural skills, in communication skills, all those. And we also teach them how to take history, how to do physical examination. So those kind of things can be assessed. So you see, the concept is that this tool will help you as a teacher and help the learner as a learner to find out what are the gaps in their learning. And then both the teacher and the learner can work together to build a learning plan to address the gap. So the purpose is to move them from level 1 to the level 5, which is, they can only be observer till, or they can practice independently. Maybe they don't reach level 5 till their final year. Maybe some of the things level 5 they reach only in internship. And that is also fine. It is about a continuum of moving them with small steps, moving them from one level to the higher level to the next higher level. That is the structure and the principle.
There's a question in chat box, ma'am. Who will take the responsibility of assessing? Senior professor or any faculty? What is the best way to record for future reference?
In competency-based education, typically what happens is there is a curriculum competence committee which decides what are the competencies the learner has to achieve. In India, that has come from the national, from the NMC documents. So who will learn? So it comes to the institutions, and then the institutions have faculty. So they design the learning assessment based on the competencies that have been defined that your learner has to agree. So it's just like this. So the faculty have to do it. The institution has to take the responsibility. And whatever your response you have to give to the university, it would be a similar structure like a current assessment system. However, it would be solely focused on achieving the competencies that have been identified by this competency committee.
Thank you, madam. Yeah, there is a question from audience.
Appa is asking about breakfast, I think. Then he
Good
doesn't
morning,
want to
ma'am.
do DDRC.
That was an excellent presentation from your end. Ma'am, I have one question that at the end of the day, what I understood is workplace assessment is more from a postgraduate point of view, it applying for them. But isn't it ground reality what is happening is postgraduate assessment, what the universities is conducting, the summative assessment, what I mean, has none of these elements. The summative assessment for postgraduates has not really changed than what it was existing before before CBME came into practice. Most of the universities are still sticking on to the same old assessment patterns for PG when it comes to summative. Now, when it comes to formative, even if a couple of departments are implementing these workplace-based assessments, why aren't they added to the summative assessment so that the postgraduates as well as the assessors could take these more seriously?
So
These
that
are
is a question for NMC to answer and for the university to answer. But what I would actually encourage, having gone through the Indian system myself, is you can be the advocate. Somewhere it has to start. That would be my recommendation and suggestion only. And, you advocate, and university may change, may not change. I don't think I have the answer for why university is not changing or why university is doing in a particular manner. But I do know that if we train our faculty in these skills, our day-to-day formative assessment at least will improve to such a level that there will be tremendous learning improvement for our learner. That I can tell you. That is something which we can do, which is within our power.
Thank you, madam. Any other question? Yeah.
Thank you, ma'am, for the great energy and key takeaways, ma'am. Your expertise, 3 steps in WPPBA pushed us to the next professional level, ma'am. Thank you very much, ma'am.